Um, Rheumatic disease is a disorder of the immune system, and these patients are usually on medications that modulate the immune system. Since COVID-19 also affects the immune system, the patients with these diseases might have many apprehensions regarding the vaccination. Today we have here with us Dr. Manjari Lahiri, who will be interviewed by me, Aanandita Kapoor, Kumble, and Vedanshi Seth. Dr. Manjari is the chairperson of the chapter of Rheumatologists, Academy of Medicine, Singapore. Dr. Manjari has recently led a team of doctors that published a research paper titled Recommendations for COVID-19 Vaccination in People with Rheumatic Disease, developed by the Singapore chapter of Rheumatologists. Welcome, Dr. Manjari. Thank you for making time for us today. So the first question the first question we wanted to ask you was, how do you define like the group of people, like people with rheumatic disease? How do you define that group?
Yeah, it's a great question because, when you say cardiologist, everyone knows what heart disease is and what cardiologists do. But when I say I'm a rheumatologist, a lot of people don't really understand. So rheumatic disease are basically a group of diseases which are autoimmune, which means your own body's immune system is turned against you. So normally your immunity is supposed to fight infections, fight bacteria and viruses, but sometimes it's confused and it attacks your own body. This can be any organ. So typically rheumatologists are doctors who look after people who have these autoimmune diseases. And when these people who suffer from these diseases are basically who we're referring to as people with rheumatic disease. Very often the joints are affected. So people do also refer to us as the joint doctors. But that's not entirely accurate because many of these diseases affect a lot of organs in the body, including the brain, the heart, the kidneys, the lungs, the skin, and so on. So they are very often multi-system diseases, and these patients have a disorder of the immune system.
So, doctor, are the people with rheumatic disease at increased risk of developing COVID-19 complications, and do they need vaccine protection more than others?
Yeah, absolutely. And that's a great question. So the first part has actually been answered. So there was a Global Rheumatology Alliance, which is a global effort in which people sort of keyed in their data on their patients with rheumatic disease who end up getting COVID, and they looked at the outcomes in them. So how many needed hospitalization, how many needed ICU support, and how many died of the infection. And while there's no comparator group and you can't directly compare it because you need some statistical analysis, etc., but in general, just looking at that number, it does seem higher than that we see in the general population. There's another meta-analysis done of Asian studies, which in fact two of my colleagues in Singapore were involved in. And that again did show that patients with rheumatic disease, they might have the same risk of catching the disease, but if they do get the disease, then certainly they have a higher risk of having poor outcomes from the disease and having more serious disease than other people. So yeah, the second part, so definitely because of that, we actually do want to prioritize these patients for vaccination. And in fact, in a lot of countries, including the UK, so UK had this list of clinically extremely vulnerable people who they prioritize for vaccination, and people with rheumatic diseases were actually included in this group of CEV.
And doctor, is there data to prove that existing vaccines against COVID-19 are safe and effective in people with rheumatic disease?
Yeah, unfortunately, not direct data, so we extrapolate. So what do I mean by that? So there are lots of vaccines for COVID now, which are available in various countries. Unfortunately, almost all of them excluded patients with rheumatic disease. The Pfizer trial did include very few patients, just about 60 patients, but even those were patients who were not on immunosuppressants, so not on medicines that would suppress the immune system. And the reason for doing this is not because of a safety concern, it's because of an effectiveness concern. Because when you do trials of vaccines, you want to get the best possible response. So if you think that someone's immune system may not be able to give a great response, you will exclude them for the initial trials. They'll usually be excluded in subsequent trials when you want to expand the reach vaccine. Unfortunately, in COVID, we don't have time. We could wait for all these trials to come out. But then, as we know that these are the patients at higher risk, so do we really want to subject them to that high risk while waiting for that? So that's one. But we do know from other vaccines like pneumonia vaccine or influenza or flu vaccine, which we routinely give to our patients. And these vaccines have been given for years, many, many years, patients with rheumatic disease. So what do we know about vaccines from them? We know that these vaccines are safe. Flu and pneumonia vaccine do not cause flares of rheumatic disease, so it's not like they trigger the immune system and make your rheumatic disease worse. They also don't cause any unusual side effects that would not otherwise be seen in other healthy people. And they're effective. Some of the drugs we give do decrease effectiveness by a little bit. So instead of maybe 100% response, you might get a 70, 80, 90% response. But that's still better than zero and still better than not being vaccinated. So some protection, and it's a reasonably good protection. It's not that you don't get enough protection. You actually do get reasonably good protection, but it may not be the same as that in healthy populations. Again, this is what we're extrapolating from others. The main concern is with live vaccines. So there are some vaccines like the polio vaccine or one of the herpes zoster vaccines, which use a live virus. And in those, we're a little bit more careful because if you have a live virus injected into you and your immune system is suppressed, you can actually get disease from the live virus. But thankfully, none of the COVID vaccines which are on the market or even in the later stages of development, none of them are live vaccines. So for COVID, this is not a concern at all. So to summarize, no safety concerns from COVID vaccine, though we don't have direct data. Effectiveness may be slightly decreased, but it's still likely to be good effectiveness. So yeah, that's why we still recommend it.
The next question we had to you was regarding the phases of the disease. I read that there are like quite a few phases of the disease. So in which phase should the COVID-19 vaccine be administered for like those people with rheumatic disorders?
So you're asking about phases of rheumatic disease?
Yeah, in which phase should the vaccine be administered?
Yeah. So yeah, we don't really call it phases of disease, but rheumatic disease do tend to flare. In Western mostly of active disease because they haven't been treated yet. So in our recommendations, we have put in a conditional recommendation. And you'll notice that a lot of our recommendations are conditional because they're not really based on solid evidence, but they're based on expert opinion of a whole group of doctors. So we conditionally recommended that vaccination should be done when the disease is reasonably well controlled. However, this needs to be taken in context. In Singapore, the risk of getting COVID is actually pretty low. We don't have much community cases and the risk of catching COVID in the community is low. So you can afford to be a little bit more cautious and perhaps wait for the disease, your patients with rheumatic disease, for the disease to be well controlled before you go and vaccinate them. The situation is completely different in India. In India, every little bit of waiting actually exposes you to the risk of getting COVID because the risk of getting COVID is just high. So in India, we would totally contextualize that in a different way. And we would say that, look, don't delay. Your risk of having a flare of rheumatic disease is much more manageable than if you were to get COVID. So the overriding concern here is prevention of COVID. So in India, I would say just go for it. Go for it right away. And don't worry about active or inactive disease.
But doctor, should the people continue immunomodulatory drugs when they get vaccinated?
Yeah, so they should. So for most drugs, actually, especially in patients with well-controlled disease, they tend to be on low doses of drugs. So these low doses of drugs actually are not expected to affect the immune response very much. There are some drugs in particular we are a little bit worried about, which is why I mentioned that 70, 80, 90% response, and it may not be 100% response. Because some drugs we do know decrease the effectiveness of vaccines a little bit. And again, this knowledge comes from flu and pneumonia vaccines, not from the COVID vaccine, because we don't know. But in general, because we just talked about flare of rheumatic disease, and certainly we don't want the rheumatic disease to flare, and some of the disease can be life-threatening. Like I said, it can involve the brain, the kidney, the heart. So the last thing you want is a big flare-up of rheumatic disease. So in general, balancing the effectiveness of the vaccine and balancing the risk of flare. And just to make it simple, because there are alternative recommendations from the American College of Rheumatology where they do actually recommend some minor adjustments to medications. And we thought about it and we discussed it a lot. And we actually went with not interrupting most medicines, and I will discuss Rituximab in a bit, but other than Rituximab, we said just carry on, partly because we want to balance the risk of flare, partly because we just want to keep it simple and not complicated. There are 2 doses to all the COVID vaccines, so you interrupt once and then you have then it's time for the second dose, so you interrupt again, and it just becomes really hard logistically. So yeah, we're happy with recommending no interruption to treatment.
And doctor, would you give any particular advice to patients administered with rituximab?
Yeah, so rituximab is a little bit tricky because rituximab, so what rituximab does is it's an anti-B cell treatment, and B cells are actually the precursors of plasma cells, and plasma cells are the cells that produce antibodies. So what rituximab does is pretty much wipes out the B cells. So because it wipes out the B cells, the antibody response is markedly decreased. So rituximab is a bit of an exception to my previous answer, that patients who are on rituximab are very likely to have a very minimal or very suboptimal response to the vaccine, sometimes even no response to the vaccine. So in a sense, rendering it useless. Even now, the question is not about safety. There's no safety concern, but it may be that you get the vaccine, you think you're protected, but actually you're not, because you didn't develop any antibodies, because rituximab prevented you from developing antibodies. The other problem with rituximab is a long-acting drug. The dosing is every 6 months. So once you've taken it, it's kind of there in your body for 6 months. So what we have recommended is actually to wait for 6 months after rituximab to get the vaccine, and then get the second dose of vaccine, and then delay the next rituximab dose to about a month after the second dose. Again, these recommendations were made for Singapore. They really need to be contextualized. If someone in India comes for a vaccine, like I said, there's no safety concern. So if in the ideal state there's no vaccine shortage, perhaps they can go ahead and get the vaccine now and then maybe get revaccinated again later. We don't know. So we have no data on revaccination. We have no data on boost on 2 doses. So we're literally working with the knowledge that we have, which is obviously going to evolve and is evolving very fast. So there's new information coming out, so we need to keep up. But yeah, if possible, if the risk of infection can be managed, then yes, to get a good response from rituximab, ideally vaccinate about 6 months after the dose, or at least 4 months after the dose, if possible. If possible, and I'll qualify that as if possible.
So Dr. Manjari, the next question we had for you was, should these patients get antibody titers checked after COVID-19 vaccination? So Dr. Lahiri, the next question we had for you was, should these patients get the antibody titers checked after COVID-19 vaccination?
It's a great question, Aanandita, and in fact, it's a subject of research. One of my colleagues is involved in that research, and as far as I know, there's one paper published so far in which they looked at antibody titers after vaccination in patients with rheumatic disease, and thankfully that paper was quite encouraging. They did have good antibody responses, though there was slightly less than that in the healthy population. Very small study. Outside of research studies, we actually don't recommend it, mainly because A, we don't know how to interpret the results really, and B, we don't know what to do with the results. So I'll tell you what I mean. So you may have a low level of antibodies. Does that really mean you're not protected against COVID? We don't know, because you may have a very good T cell response. And in fact, in viral infections, T cells are a very important part of the immune protection against COVID. You may not have a good level of antibodies, but you may have a good memory of the antibodies. So if you're exposed to the COVID virus, you might mount a really good antibody response. So low levels of antibodies may not mean low protection. So that's one. Two, even if we do assume that low levels of antibodies mean low protection, what do we do about it? You see, do we give you a booster shot? Do we repeat the whole course of vaccination? Do we give you a different vaccine next time? We really don't know. So these are all unanswered questions, and certainly we need more research, and probably 6 months from now, we will have a good answer to that question. But as of now, the answer is no. In clinical practice, we don't recommend checking the antibody levels.
Doctor, how important is it for the household contacts of people with rheumatic diseases to be vaccinated?
That's a great question too. Because as we just discussed, you see, patients with rheumatic disease are more prone to get severe disease. They can fall ill, and they may not have perfect or really very good response to the vaccine, right? It may be suboptimal. So what can you do? What you can do is form a ring of protection around them, because a lot of infections are actually from your close household context, right? We see whole families coming down with COVID. So if the whole family is protected and the rest of the family who don't have rheumatic disease are all vaccinated, and they're less likely to catch the infection, but also less likely to transmit it to the patient with rheumatic disease. So in a way, you're indirectly adding extra protection to this patient. So you're forming kind of a ring of defense around that patient. So yeah, that's a really good strategy to adopt, actually, to encourage patients' family members to go and get vaccinated.
And doctor, are there any specific suggestions for vaccines for patients with rheumatic disorder?
I wish, but no, they aren't. So like I said, none of the trials actually included patients with rheumatic disease. So if they would have, then we might have had a preference. But as of now, we have no reason to believe one vaccine works better than another in terms of its mechanism of action. So as of now, and as I said, none of them are live vaccines. Yeah, so we would be worried if any of them were live vaccines, but none of them are. So as of now, there's no preference. So long as the vaccines have good, solid phase 3 data, which has been published in peer-reviewed journals, and they have been licensed for use based on these data, we are actually recommending to get any vaccine, depending on whatever is available in your country or region. Just go for it.
That was like, you answered all the questions we had, Dr. Lahiri. Thank you so much for taking time off to talk to us.
Thank you so much for inviting me, and I hope this helps to reassure patients. A lot of our patients have questions, so all of the questions you asked are very valid questions. So I hope this addresses some of their concerns and encourages them to get vaccinated. Thanks so much, you guys, for doing this. Really appreciate it.
Thank you, Doctor.
Bye.